afternoon. I'd like to welcome you to today's Medical Center Hour, a program called Are We Misunderstanding Advanced Directives for End-of-Life Care? I'm Marcia Day Childress from the Center for Biomedical Ethics and Humanities, and I'm pleased to see all of you here this afternoon for this program. Advanced directives, which frequently used to be called living wills, are legal documents that enable a person to declare his or her wishes about medical treatment and end-of-life care and have those wishes followed even when he or she no longer possesses decisional capacity. An advanced directive also allows its maker to identify another person as his or her healthcare proxy, appointing this other person to make decisions on the patient's behalf, again in the event that he or she is personally unable to do so. For years now, advanced directives have been urged on the American public as means both of maintaining personal control over healthcare and of guiding health professionals in their care of persons who have complicated illnesses or are at the end of life. But for all the good such forward-looking documents and the clarification of values and anticipatory decision-making they represent, for all the good that these might do, a relatively small percentage of Americans have executed advanced directives. Why is this? What are the barriers to making one's wishes known in this way and to identifying a surrogate decision maker? Even as states like Virginia promote citizens' use of advanced directives, what social and cultural counterforces and even some historical counterforces might be in play? And even when a patient has an advanced directive, does the healthcare establishment, including the individual health professionals involved in the case, always know how to use it, especially in end-of-life situations? In this year of big changes, both the heated healthcare reform debate and the adjustments in Virginia law that affect the declaration of wishes regarding medical decision-making, this Medical Center Hour seeks to explore how and why we all may be misunderstanding somewhat both the making and the following of advanced directives. So in hopes of learning why this situation is so fraught with difficulty, and in hopes, too, of learning how best to move ahead with advanced directives in healthcare, we offer this program with two speakers from the UVA medical faculty. Our first speaker will be Dr. Leslie Blackhall, who's on my far right, an internist and palliative care specialist who has additional expertise in bioethics. Dr. Blackhall's work engages her regularly in challenging conversations with patients and their families and with other clinicians regarding decisions for end-of-life care. What role do patients' advanced directives play in her work? Or more commonly, why don't the majority of her patients have advanced directives? Where does reluctance to have an advanced directive come from? And what does Dr. Blackhall do to help her patients and those close to them plan for later tough choices, including executing advanced directives? Our second speaker will be Lois Shepard on my immediate right, a lawyer and bioethicist here in our Center for Biomedical Ethics and Humanities. She will address briefly some legal and political aspects of advanced directives, and will look forward at some new ways here in Virginia that advanced directives can help patients and their healthcare teams plan better for end-of-life care. You may have noticed when you came into the auditorium or as you're going out, there are copies here of a brand new advanced directive form from UVA, which conforms to the recent changes in Virginia law and offers, as Lois Shepard will point out, some additional areas in which patients can register their preferences. Also, let me announce right now that this week and next we'll be doing 2 Medical Center Hours each week. So our second program this week is a program tomorrow afternoon, Thursday, the 29th of October at 5 p.m. in this auditorium. This is not a duplicate program in any way. The speakers are Amy Abernathy and Donald Taylor from Duke University, talking about healthcare reform, the current debate and where we are, and end-of-life care. This is co-presented, as is this program, with the Department of Radiation Oncology. and the Pfizer visiting professorship, which Dr. Abernathy holds, and she will be the main speaker tomorrow. So now we'll begin with Dr. Blackhall, and I hope that we'll have a lot of time also for your questions and comments.
Can you hear me? Is this? So this medical center hour actually was originally scheduled to be given by Amy Abernathy. But as we were planning her visit here from Duke, she was invited to go talk before the Senate about end-of-life care, palliative care, and healthcare reform. And that seemed like such an excellent opportunity for her to come back and tell us what's going on, that what we elected to do is to have us sort of start the conversation about some of what has been happening historically about end-of-life care planning, and then continue with her giving us really the up-to-the-minute breaking news. And I really encourage everybody to come tomorrow. I know that I am really looking forward to this. So basically, you know, this has been incredibly controversial, the whole healthcare reform thing, and any of us who lived through the Clinton era attempts to reform healthcare are not really surprised by, you know, all the issues regarding government healthcare and communism and socialized healthcare. But for whatever reason, I myself was actually shocked by the degree to which my profession, and you know, those of us, anybody who talks about this suddenly exploded into the headlines with all of this death panel business. So, and I know that this was not just a few people, because I was actually at one of Tom Perriello's, you know, meetings, and as some other people were, and people were coming up, you know, talking in coded terms. Maybe, I don't know that I heard anybody say that word, but they were definitely implying a lot about this issue. So for those of us who were not as obsessed with this issue as I was, and I was obsessed enough to decide I was going to change my name to Death Panel at one point, I'll tell you exactly what it was about, because in fact people who were coming up to the podium and talking about it would refer to the page on this bill where it was. So what is a death panel? Well, this is the bill that they were that was the only thing out there in August. It's the bill that was passed by the House, and it's called H.R. 3200, to provide affordable quality health care for all Americans and reduce the growth in health care spending, and for other purposes. Ooh, could they be? Okay, so this is the nefarious section, I believe it's 1233 or something like that, which, oh look, I can see it here, it's much easier. It allows, so what is this horrendously scary death panel section of this bill? And now this is not a paraphrase from me, this is lifted right from the bill itself. So I went to Tom Perriello's website and I copy and pasted it. And this allows a practitioner such as myself, or I'm seeing some other people in the audience here who have these conversations, to bill for A, an explanation by the practitioner of advanced care planning, like these documents here. B, an explanation by the practitioner of advanced directives, including living wills, durable power of attorney for health care, and their uses. C, an explanation for the role and responsibilities of a healthcare proxy. D, listing the resources. And E, an explanation by the practitioner of the continuum of end-of-life services and supports available, including those notorious death panelists, palliative care, and hospice specialists. So sorry, I'm being a little sarcastic, but that's what that was. That's the thing in that bill that led to people having those signs about death panels. So there it was. It doesn't, it didn't say that you had to do those things, or that everybody was forced to do those, or that you had to fill out a living will. It simply said that people who have those conversations, which can be very time-consuming and difficult, could actually bill for them. So that's what that was about. So the absolute fury that was, happening around that made me feel like we should sort of go back and look at how it is that we sort of came to be doing things the way we're doing them. Because so much emphasis being placed on these conversations and these documents that, as Marsha pointed out, are often not used, and there's a lot of weird legal things about them. How did it come to be something that is sort of actually a day-to-day thing in the hospital? We do this every single day. We have to talk to people about their choices, and every human being in their family and in their life will have to have such conversations. How did we get to this incredibly place where people can be so angry and messed up about it? And so this is, I'm going to try to do this fairly briefly, but I want to go over some of the historical issues and controversies and even court cases, which I'll do the best I can with, and then you can tell me if I got it wrong. And so I'm going to actually start this whole thing in 1960, which was the invention of cardiopulmonary resuscitation. So defibrillation came before that, mechanical ventilation, but until that time, if you had a cardiac arrest, that was the end of your life, you died. And so, but in 1960, this guy Cohenhoven and a couple of other people wrote this paper in JAMA, and he was not a physician, and people who have heard me give this talk, parts of it before, know he was an electrical engineer who worked for the phone company, and the issue he had was those guys who would touch the wrong wire. And then he learned, and then they would have a ventricular fibrillation and die, and he learned that they could have been saved if they got to a defibrillator. In those days, they weren't portable, you couldn't have them, and so he needed something to keep their blood pressure up. And so he got together with a surgeon and an anesthesiologist, and they came up with that pumping up and down on the chest and the breasts and that whole business, and they reported 20 cases, and 70% of them lived to discharge, which is many times by many times the best rate of survival to discharge anyone ever got, because these were people with very acute reversible problems. So, but the problem after, like 2 weeks after this paper came up, the problem was, how do we get it to people? Because mostly you didn't know about it, right? Most people didn't know about it unless someone read it and bothered to learn about it. And so the solution, which sort of came as a joint push from the American Medical Association, the American Heart Association, and eventually JCO, was universal training of medical teams and the development of these code teams where, when somebody's heart stops, they call a code and everybody runs out and does that thing that you see on TV. Except it's not quite like they show it there usually. Okay, so that's sort of what was happening during the 60s. So all of a sudden you're expanding availability because everybody who's in a hospital learns how to do it. The nurses, the doctors, the emergency room personnel, the EMTs. However, all of a sudden, once you've developed this procedure that is widely known, and instead of, when it happens, you look through and see if they should get it, but there is a, when you find the patient down, we instantly go do it. You've changed the criteria for doing it. CPR was originally developed for people with acute reversible causes of cardiac arrest. I know this because I actually read the literature from the American Heart Association back then. And so all of a sudden, instead of having people who are having myocardial infarctions, drug overdoses, anesthetic accidents, people who touch the wrong wire or whatever, every single person who dies in a hospital is potentially eligible for CPR. Because as every medical student who becomes an intern learns, that when you're writing the death certificate out, like there's a list of causes. Well, they tell you not to do this, but when you start up, you always put cardiac arrest because everybody died. When everybody dies, their heart stops. And so potentially, since you have this new miracle thing that can restart your heart, all of a sudden, we're starting to do CPR on people with end-stage cancer and COPD and all sorts of conditions where when they got that far in the past, it was clear the patient was sort of dying. Of course, now you have resuscitation. And so, so that's becomes something of a problem. Like, since we're all doing it, how do we not do it? And studies started to be put out which showed that, a lot of people really don't do that well with this. This is just one. There were many, many of them in the 60s. And that although a third of people survived initially, 15% survived to discharge, and nobody with cancer, sepsis, or GI bleeding survived to discharge in this study. And I'm not going to review all that literature, but it was quickly clear to people to physicians, that there were groups of patients who really, this didn't work very well for them. But CPR was now standard of practice, so how do we not do it, you know? And so, and I always tell people when I was a medical student in New York, they were writing DNR orders on the blackboard in the nurses' station because they were afraid of doing them like in the medical record. So here are the questions people are asking themselves. Is failing to do CPR, is not doing CPR, otherwise known as, at the time, allowing the patient to die, is that sort of ethically or legally the same as killing the patient? You know, people were really concerned about whether that was so. Can we do it ethically? Are we going to be arrested if we don't do CPR? In fact, there was some cases, including a very famous one in California, where the ICU staff was having a discussion with a patient's family about withdrawing life support, and one of the nurses' aides called the sheriff, who arrested the doctor. And so there were a lot of concerns about this at that time. And then came this case, and people who are of my era remember this face. It was the face that was on many, many magazines and sort of like the Terry Schiavo of the time. And her name was Karen Quinlan. She was a teenager, I think, or maybe early 20s, I can't remember, who took a lot of drugs, street drugs, maybe some Valium or Quaaludes or whatever they were doing in those days, and was drinking, and came in after, you know, she passed out, she aspirated, she had a respiratory arrest. They brought her into the emergency room. They intubated her, they put her in the ICU, and then she never woke up. And she was felt to be in a vegetative state, and in addition, they couldn't get her off the ventilator. So she was living in the ICU. Every time they tried to get her off the ventilator even, not only was she permanently unconscious, but she wouldn't, you know, wean from the ventilator. And it was accepted as a matter of fact in the court case that were she to be taken off the ventilator, she would die. And her father, nevertheless, after some time said, this is enough. You're telling me she's not going to wake up. Why are we keeping her body alive here? And he and the physicians refused to take her off. I think they were worried about their legal liability. I'm not sure where they stood on it ethically. In point of fact, the person who was most supportive to this case was Karen Quinlan's priest of the Quinlan family. And so that case went through up to the New Jersey Supreme Court. And this is basically what they said. The New Jersey Supreme Court said that in the case of terminal illness or permanent unconsciousness, extraordinary treatments, such as CPR and mechanical ventilation, may be refused, although not ordinary treatments. And in that, they were almost word-to-word following. And they actually quoted, and I have a longer thing from this, but you can't really read it on the slide, a Catholic ruling from Pope Pius XII, I think, who answered a question about keeping someone on a ventilator from a group of Catholic anesthesiologists. So this idea that refusing extraordinary treatment for people who are like ventilators, for people who are terminally ill or unconscious, is not a form of killing, it's a form of allowing to die, and it's accepted under Catholic dogma, was almost completely taken by the New Jersey Supreme Court, as far as I can tell, as part of the basis of how they wrote this. And from an ethical point of view, what they were emphasizing, one of the things they emphasized in this case was the idea of patient autonomy, which grew to be one of the main ways we thought about this stuff. That people have the right to refuse treatment. That it's sort of one of their basic rights, that they have the right to control their body, so that if Karen Quinlan was awake and alive, she'd have a right to pull that tube out and say, I don't want it in. And that since she would, I think everybody viscerally would feel that she would have the right to do that, she has the right to do that anyway, even though she's completely unconscious and can't pull the tube out, if you get what I mean. And so what they said was that she does not lose the right to refuse that ventilator. But she can't tell us what she wants, so somebody has to tell us what she would want. And so her father, her family has the right to tell us what to do in this case, but they have to do so by telling us what she would want. It's not about what Mr. Quinlan or Mrs. Quinlan or the Catholic Church would want. It's about what Karen would want. So there in New Jersey, there was this very famous case that said they have the right, in balancing the state's desire to prolong life and people's rights to make their own decisions. On that continuum, people have the right to refuse these extraordinary therapies. And their families can tell us what they would want, not tell us what the patient would want. So The next case that I want to talk about, although there were many cases, but Paul Brophy was a very important case. He was a firefighter who had a big leaking aneurysm. And those surgeries on those types of aneurysms were even more dangerous to operate on than they are now, much more dangerous. He was told that either this thing was going to blow in his head or he could have surgery, in which case he might not even make it out of the surgery. He did not have any good choices at that time. So he elected to go for the surgery, and prior to the surgery, from what I understand, he said something to his wife to the effect of, if I can't hold my daughter again, what's the point of life? I would not want to live. So I'm willing to take the chance for the surgery. Well, he took the chance for surgery, and he came out of it in a vegetative state. He had a big intracranial hemorrhage during that procedure. He did not require the ventilator. Oh, and by the way, does anybody remember what happened to Karen and Quinlan? They took her off the ventilator, but she lived. And she was maintained on a feeding tube for 5 or 10 years, by the way. And actually, her family opened a hospice, or they contributed to. There's a hospice in her name in New Jersey. Okay, so he was maintained on just a feeding tube. It was a G-tube directly inserted into his stomach. And after it was clear to his wife that he was not going to wake up, she said he would not want to be kept alive in a comatose state by this feeding tube. I want it stopped. And so the doctors were reluctant to stop it because it seemed different to them. The mechanical ventilator seemed extraordinary. This seemed like food. Is that really extraordinary? I mean, and so actually, George Annis, who's a healthcare lawyer who I worked with for a little while in Boston, actually went to some of these court cases, said really, literally the judges were looking at the tube saying, it doesn't look too extraordinary to me, or it does, or whatever. So, and so here was the question. Was it legal to remove the gastric tube? Was it ethical to remove it? Was this G-tube extraordinary treatment or ordinary? I know this language sounds weird, but at the time we were somewhat obsessed with it. Was removing it letting him die? Because he has if he wasn't getting that, if we hadn't invented G-tubes, he would have died, right? Or were we killing him because the cause of his death would be dehydration? And so the Massachusetts Supreme Court found, first of all, that his statement to his wife prior to the surgery was a pretty good indication that he wouldn't have wanted his life sustained by that G-tube. And they also said, look, the distinction about the treatment itself, it seems incoherent. That is, a G-tube for someone who had an injury to their esophagus, which is going to heal, and go away, or they could live a long life despite, doesn't seem extraordinary. Just like a ventilator during surgery for a brief period of time, that's not extraordinary. It's not the treatment itself, it's the context, it's the benefits and burdens, and the person who's best suited to weigh the benefits and burdens is the patient. Of course, Paul Brophy, like Karen and Quinlan, is not capable of weighing the benefits and burdens, so it's left to Mrs. Brophy, or whoever his surrogate is, to tell us what he would have wanted. And and they said, and a G-tube, truthfully, that delivers food doesn't seem to them any different than a ventilator which delivers oxygen. So there it is. So they said that patient autonomy part is more important than the treatment itself. And so people can refuse that. And so here's Nancy Cruzan. So some of you might remember Nancy Cruzan. This is another very famous case, more famous, I would say, than Paul Brophy. It is the first one, I believe, that went all the way to the Supreme Court about stuff like this. This was in 1990. Cruzan versus the director of the Missouri Department of Health. And that's what it was called. So she was another young woman who had really no pre-existing medical conditions, of any significance. And she had a motor vehicle accident. I think her head went through a windshield. She wasn't wearing a seatbelt, which everybody should wear, by the way. And she was was treated very aggressively for a long time, and they finally decided that she was in a persistent vegetative state. She also had a G-tube, and she was living in a nursing home with a G-tube for many years. 3 years she was in the nursing home. Her father had been praying for a miracle, from what I've read of what he wrote, and then by 1987 he said, okay, I believe that that's not going to happen. She's not going to wake up. She's permanently unconscious. We're just keeping her alive in this nursing home by the stuff they're giving her through her feeding tube, and she would not want to be living in a nursing home completely unconscious. It seems undignified. It's no quality of life. I want to be feeding tube. So They refused, and they went all the way to court, and I believe there's a Frontline documentary about this that starts where they went to the Missouri Supreme Court and goes up. I think I never saw the whole thing. And so the Missouri Supreme Court refused to allow the Cruzan family's request to remove the feeding tube, and they kicked it all the way up to the U.S. Supreme Court. And so here is the 1990 ruling essentially said these things. They reaffirmed in the Supreme Court what most of states that were dealing with this had already said, that patients who are awake and have capacity have the right to refuse treatments, including feeding tubes, even if they'll die. 8 of the 9 justices agreed with that, except for Justice Scalia did not agree with that. So I guess he felt that even if you wanted to not have a feeding tube, you had to have it. Secondly, if the patient does not have capacity to make the decision, like clearly Nancy Cruzan was completely unconscious, like Paul Brophy and also like Karen and Quinlan, then the family or the appropriate surrogate can make the decision based on the knowledge of the patient's wishes. The issue is, the family isn't to say, well, I don't want him to live this way, or it's too much trouble for me, or whatever they want to say. They need to tell us what the patient would say. Now, recognizing that people don't necessarily know what their loved one would want. Maybe people in this room have all talked to their loved ones about what they want. Certainly I have ad nauseum. I can't really sick of it. Get around the Christmas tree and those are living wills. Well, I know we're odd, okay? Mostly we haven't, we know this. So the question is, how much information do we have to have, right? And so basically, not to be too intense about it legally, but in most states there are different standards of evidence. And one of them would be preponderance of the evidence. That means you say, well, I'm Uncle Joe's only surviving relative, and I'm his niece, and we never really talked about it, but he was an independent old cuss, and he would never want to be left like that. Well, if there's no one else to say anything, there's more evidence that side than the other. But clear and convincing evidence would be like, Uncle Joe and I watched that Frontline documentary about Nancy Cruzan, and he said, I would never want a feeding tube if I was in a vegetative state, right? It would be sort of more specific. And so what they did say was that states, individual states, if they wished to, could insist on that level of evidence, like really clear evidence of the patient's wishes. Sandra Day O'Connor, in her opinion, suggested that advanced care directives were a way of establishing evidence of a patient's wishes. In fact, documents like this started right after the Karen and Quinlan case, because people began to see, well, if it's based on what people would want, right? And how do we know what people would want? Maybe we should start telling people what we want. And so these first living will things were sort of like statements that said, if I'm like in a vegetative state or terminally ill, I don't want any of that stuff. And they were pretty vague and difficult to follow. And so states were experimenting with different forms of documents, and still are really. And during this whole time, people were trying to figure out what is the best possible type of document to support people's ability to say what they would want. Now, if you're, have a specific problem, I work in the ALS clinic sometimes. Those patients are going to have specific problems, right? ALS is a disease that will affect your ability to swallow and to breathe. And so early on, you should probably be thinking about, would I want to be on a permanent ventilator? Would I want to have a feeding tube? People with cancer have specific things. But Paul Brophy, Karen Quinlan, Nancy Cruzan, these were people who didn't, and Terry Schiavo, were people who didn't have pre-existing conditions. So someone like myself, who presumably is pretty healthy now, can I think of every possible thing that might happen and how I would feel about it in advance? In fact, Ezekiel Emanuel, who's the brother of Rahm Emanuel, who's Barack Obama's enforcer guy, sort of, he's a very famous bioethicist, and he actually came up with this document that was like 4 different conditions and 20 different treatments, and you sort of could check off the things you'd want or didn't want. And that seemed clumsy and unwieldy. And then there were documents that just named a person, and that had problems because they did some empirical research and found that people really did not have a good understanding of what their loved one would want. So they developed a variety of documents that including this one here, that has sort of both parts. Naming someone, but also allowing them to name some wishes. Okay, so what happened? Yes, I'm almost done. I only have 2 more slides, believe it or not. So Nancy Cruzan, they sent the case back to the Missouri Supreme Court to see if she did have clear and convincing evidence of her wishes. And in fact, some college roommate or somebody, I think, came up and said, you know, we did talk about this in the past, and I think they were talking about the Quinlan case even, and she said she wouldn't want this, so they elected to remove the feeding tube. And these are people who are chaining themselves to the doorways of the place where, you know, it's very similar to the Terry Schiavo thing. That's just pointing that out, which is that case, which I think everyone remembers, so I'm not going to talk about it. But the reason legally that case never went anywhere was that it was exactly the same as the Cruzan case in almost all particulars, and even Scalia, I believe, didn't want to rehear that case. But you know much more about that case than me, so I'm not. Okay, so here's the question. We're coming back to the beginning slide. Why is advanced care planning equivalent to a death panel? Why is that? Now, I would say it's not. Okay, I mean, I'm not really sure what a death panel is, but whatever it is, I don't think it's that piece of paper. But the legal and ethical reasoning that led to the development of these things, okay, also were cases in which the right to remove life support, including in nutrition and hydration, was established. So there is a connection in some convoluted way. And also I have to say that these are documents that sort of admit, as I think we are getting better at doing, that, you know, people are mortal, that everybody dies, that if you're going to do good medical care on people, you have to include the idea that no matter how great a doctor you are, no matter how you're on the top 10 hospitals in this part of the galactic empire or whatever, everybody still is going to die. And therefore, we have to sort of think about that. And I think that makes people uneasy. I don't think people necessarily want to think about that, which is why they don't necessarily want to fill that out, because as one of my favorite quotes from a lady who wrote about a big bioethics trial said, you know, people want a peaceful, comfortable, and dignified death, but they do not want it quite yet. Which is me too. I want it, but later. Okay, and so just, I'm going to turn it over by saying that here are the things that I see that are not really controversies that is in practice. These are things that happen all the time, but clearly still punch a hot button politically. Although it's legally permissible and frequently done to withdraw nutrition and hydration every day in the hospital, I would say many times a week I'm asked to see people in whom these sorts of decisions are being made when I'm on the inpatient side. People with huge intracranial hemorrhages, end-stage Alzheimer's disease, cancers or ALS. It's very common. But is it ethically withdrawn? And the thing that seems to punch people's buttons the most is the nutrition and hydration thing. And almost always in these dilemmas, these are people who lack the capacity to tell us what they would want. And why is that? Because the inability to swallow is often associated with severe brain damage. It wasn't incidental. You know, the need for a feeding tube was the same as the reason why these people couldn't tell us what they wanted. Coma, stroke, dementia, okay? That's number one. And the other reason why this is a controversy under these conditions is that I don't think there are many people, maybe Scalia is different because of how his decision, who would force feed someone who is sitting there and saying, I refuse, you know, if they were alert. I have had families try to talk people into it when they didn't want to have a feeding tube, say in ALS, but I don't think that anybody would argue, very few would argue legally that they should be forced to have such a thing. Does that make sense, that point, sort of? Okay. So in other words, the fact is that this is a political controversy related to withdrawing nutrition and hydration in people who can't tell us what they want, and often those things go together. And then the next question, I think, is how do we decide if a patient has capacity to make a decision? Sometimes it's obvious and sometimes it isn't, and I think that you'll be talking about that a little bit. And there's another controversy if the person cannot make decisions but hasn't filled out one of those advanced directives, naming someone to do it. who should speak for them, right? Who should it be? So if you filled one out, great, but if you haven't, who's going to be the one to do it? Well, that varies state by state, but I'm going to just say one thing. In Virginia, there's a rank order of family members, and there's language, or at least there was, specifically including common law wives and definitely excluding gay partners if an advance directive has not been completed. So this, I'm just going to stop by saying, if the whole purpose of the Supreme Court case and all this ethical mishigas and discussion was to preserve the patient's right to refuse treatment by having the person who knows them, right, speak out, one of the issues for me with the way we do things is that in order to simplify things, we have this rank order of family members, which has led, in my recent practice, for things such as the 40-year, common law wife who's sitting by the bedside in the ICU for the last 3 months gets excluded for decision-making while we call the son of the patient who the patient has not seen since he was 6 months old to make the decision. Now, who really knows the patient's wishes better? And luckily, in a lot of those cases, the one we call just says, do whatever she says, or whatever. But anyway, that is one of the problems. So I'm going to stop there and turn it over to you. I'm having a little technical difficulty. I'm looking at a slide. Good. Thank you.
Okay. Well, delighted to be here today. I want to pick up on just a couple of things that Leslie talked about here at the end, but she talked about so many things, and I can't remember everything that she talked about, and I hope that, and there were a few things that I want to talk about with respect to what we might see in the future. So I hope during the question and answer period we're able to pick up on some of the other things that Leslie talked about. But one of the things she was saying there near the end was, do some people really want to force feed people if we don't, even if we know they don't want it, right? And my answer to that is yes, some people want to do that. That might not be where, thankfully I think that's not where we are politically right now, but right after the Shivo case, or during the Shivo case, there was legislation introduced in, I think, 28 states. It didn't get very far, but it was the National Right to Life Organizations Act, Model Act that they put together, which was called the Starvation of Persons with Disabilities Prevention Act. And it would have required a writing, an actual living will, in order to stop artificial nutrition and hydration. And there were arguments at the time in the legislative committees or just in different forums about what was motivating that, and the answer that was given by those who were in favor of it was that it was motivated by trying to respect patient autonomy. And the idea was that we want to make really, really sure that's what the person wants, to refuse artificial nutrition and hydration, which will cause their death, most certainly cause their death in the conditions that these patients were in. But because so few people, percentage-wise, execute advanced living wills, advance directives. And here we didn't need just an agent appointed. You would need an actual directive that said, I refused artificial nutrition and hydration in that condition that the patient had. That's how specific the proposed legislation was. So you'd have to have a writing, and this was promoted on the grounds that we know really for sure then what the patient would want. But because so few people would have executed these things, at the same time, we know that like 70% or higher, according to different surveys, of people say that they would not want artificial nutrition and hydration if they were in a permanent vegetative state. If they haven't, 15 to 30%, surveys differ, on how many people have executed these living wills, we can see we wouldn't be actually reflecting what people's wishes were if we had an act like that. So it was really about preserving life. And that's what we saw in the Shivo dispute, was this conflict between preserving choice and preserving life. I think it's much more complicated than that, but that's often how it got played out in the media and in the way people talked about it, was that there are only two choices. We're going to preserve choice or we're going to preserve life, and that you had to be on one side or the other. So that's with respect to what do some people want. And I think also with respect to what Leslie was saying about Virginia law, and I think the idea that we have this surrogate listing that does not allow anyone but a blood relative to be a surrogate, in other words, not the common law spouse, or the sister-in-law who's taken care of the individual for many years, or the gay or lesbian partner, or other, we can imagine lots of different relationships, a very close friend, in which that person would actually know the patient's wishes better. If we were really supporting patient autonomy, then we would have a way for that surrogate who would most know the patient's wishes or be able to speak for the patient to be able to step in and make those decisions. And right now, that's not possible in Virginia. So again, some people do not really value honoring patient autonomy over some other things such as preservation of life or maybe preservation of certain traditional notions of family. I want to talk about a couple of trends that we have seen through this evolution of the law and practice in living wills. So the first is, I'd say that there's been a movement away from understanding advanced directives to be like property wills. That if you remember, if you were around at that time, we thought of them as something that you would execute in a lawyer's office. Of course, the lawyers knew nothing about this area. And also that it was something that you would do once. Like a lot of times people's wills are written that they will last for 30 years. If you do it right, and it's pretty generic, you're going to be fine. They tell you to revisit it every few years. I haven't revisited mine in 20 years. And I'm sure it's just fine. But that's not the case. We found, I hope it's fine. I need to go back. Lawyers are terribly notorious about not taking care of their own legal affairs. Maybe doctors are that way about medicine. I don't know. But we have had a greater understanding over the years that these are not like property wills, and that it's very difficult to craft these in a way that they will speak to actual circumstances that appear years later. And so what we have now, and Leslie talked about this, more emphasis on the appointment of an agent and giving the agent the power to make certain decisions. In some states, you would want to be careful about making that power explicit, especially, again, with the hot button issue of artificial nutrition and hydration. There's also been a better appreciation of when instructional directives, what we think about as the living will part of these things, are most useful, and Leslie talked about that. In certain situations, they can be very, very helpful, even though there's been a lot of criticism lately of living wills and how they fail. In some situations, they can be very, very helpful, especially when a person's condition is fairly clear and the physician can explain what the options are in the future. We also have seen this most recently, and this goes also with the idea, I think, the first point about a movement away from understanding of these as things that are more like legal documents, even though they are legal documents, and understanding them as something that physicians or healthcare practitioners need to be involved with. And so there needs to be more conversation with physicians and practitioners in filling them out. And so some policy initiatives with respect to that, in particular the Tri-Committee bill that Leslie was talking about that got accused of being initiating death panels. So that idea is not going away. I know that idea has gone away in healthcare reform. I mean, it's not going to be in the final bill. But that idea that physicians and healthcare practitioners need to be involved in this on an ongoing basis and need to have incentives to do so, I think is not an idea that's going to go away. We'll see more of it. We've seen some action on the state level. We also, I think, have a growing appreciation of the need for physicians' orders to ensure that these decisions are honored across healthcare settings and across time. We have the durable DNR that you can have a doctor sign with a patient or a doctor sign with a surrogate, and that is effective. It's not just a hospital order. It is effective across settings and across time. So emergency personnel, for example, can honor your durable DNR. And there's a movement that's been going on the last 10 years or so to expand that idea to cover other kinds of life-sustaining treatment decisions like do not hospitalize, do not intubate, those kinds of things. And actually in Virginia, they are starting to look at that as well. We are not on the forefront of that, however. Another trend we're seeing are combining within what we have traditionally understood now as advanced directives, research advanced directives, where an agent is given the power to enroll a patient. A surrogate is given a power to enroll a patient in a research study. We see on the form that you have today also information about organ donation. It's kind of a one-stop shopping kind of form now. It includes mental health issues, and that might lead to some confusion. Virginia is really at the forefront of that, and we'll see how that kind of experiment goes. Now, what are some, so those are kind of trends I would say that we've seen in the last 10 years. I think they will be continuing. Here are some difficult remaining questions in ethics and law that I think we're going to have a lot more conversation about. What should we do when there's a conflict between the instructional directive, so the directions that have been written out, and the decision of the surrogate? As a general matter, state statutes did not anticipate this problem or didn't know how to address it, and so just are silent on the issue. And so it is an open question. What should doctors do? What should hospitals do? What will courts do? And will state statutes eventually put something in the statute to give people some comfort with respect to what they should do in that situation? Another difficult remaining question is, are there any limits to patient autonomy regarding forms of treatment and care? You know, we've seen the evolution from the ventilator to artificial nutrition and hydration. There's now clear consensus that those can be removed, but we can push that a little bit further, and it is being pushed a little further with respect to hand feeding. Can you also refuse hand feeding? If you can refuse hand feeding, can you put in your advanced directive, don't even offer me food if I appear to want it? I mean, how far can we go with respect to committing ourselves in advance and committing others to follow our orders in advance with respect to whatever condition we end up in after we lose capacity? Similar question, are there limits to patient autonomy with respect to the patient's condition? So for example, I'm thinking here of the situation of a person who's fairly young and has an accident and ends up profoundly disabled. If that person in a previous clear writing said that he or she did not want to receive any artificial nutrition and hydration, would we be ethically okay to honor that request? Would we be required to honor that request? And I'm talking about a situation, I'm envisioning a situation, and there have been a few, in which the treatment is not burdensome, right? And there's not a sense that the person is suffering from his or her new form of existence, but clearly indicated prior to the accident, for example, that they wouldn't want to be kept alive in this situation and would refuse everything. So that, I'd say, is a very large unanswered question that we're going to hear a lot about in the future. What is consciousness, and how much does it matter? I think a lot of the law that was built up in this area has talked about making these kinds of decisions in two particular situations: when someone's death is imminent, which we don't really take as right away. We take that as kind of like in the next 6 months, so a terminal illness, or if someone is in a permanent vegetative state. So with respect to this idea of a permanent vegetative state, we'd like to think of there being a bright line between consciousness and no consciousness. And unfortunately, I guess as far as ethical certainty goes, we are now finding with functional MRIs that there seems to be more going on with respect to some of these patients than we previously thought. So does it matter, for instance, if a vegetative patient's brain lights up on an MRI when his or her name is called, in a way that mirrors what would happen to someone who's a perfectly healthy individual? Is that something we need to factor in to understanding what is consciousness? And why should that matter? It has mattered a lot in the past as we lopped off this category, permanent vegetative state, and got very comfortable that life-sustaining treatment could be removed in that situation. And finally, this goes to the point that Leslie made about Virginia in particular, with respect to who might serve as a surrogate decision maker. Last year in the legislative session, revisions were offered to allow non-blood relatives to serve as surrogates in the default list if they are not named as a proxy, but that failed. And so we'll see. I don't know what the, I know what I think is the ethical answer, but I don't know what we will see politically with respect to that. So that's mostly what I see as some of the things we're going to see in the next 10 years or so, and open up to questions.
Thank you. I'd like to thank both Leslie Blackhall and Lois Shepard for terrific presentations. And we have several minutes for questions, so please identify yourself when you ask your question.
Gordon Putnam, chaplain in the Cancer Center. If you don't follow that decision tree, who can make decisions if there's nobody announced, what's the consequences, legal consequences? Is there some legal consequences in the law? And do you know of anybody being charged with that? Especially when you think about the wife or the cohabitation of 40 years and the children haven't been around. And if somebody makes a decision, we're not going to talk to the children, we're going to talk to the one who knows best. What are the legal consequences of that?
I think it's a bit unknown, is what I would say. When these state statutes first started being passed, it was to give, the general idea was to give comfort to doctors and hospitals with respect to what they were already doing, which was turning to the family. So the idea was not, with respect to these state statutes, we want you to go to court all the time. The idea is, don't come to court unless you have some extraordinary situation. You guys have been doing it right, and we're going to codify that. So here's our understanding, basically, of what you do, which is to turn to different individuals according to this list. And in many states, you are allowed to turn to others besides, who's in that hierarchy. And that hierarchy includes others besides blood relatives. But I would say, you don't need to worry about it if there's not a conflict. And what the statute is doing is giving you authority to follow the blood relative's decision. But it's not saying you don't have authority, right, to follow someone else's decision. Remember, what they were trying to do is say, what you've been doing is okay, and not trying to say that it was criminal, right, or improper. And so they codified and gave you some safety with respect to some of it. But this other is kind of in the, they haven't specified it, but they're not saying it's wrong either. In other words, you're kind of in legal no man's land.
But my understanding is they specifically say that you shouldn't be talking to these people like the gay partner or the...
Doesn't specifically
say. I guess if I want to say something. Actually, California, where I came from, used to, the rule there, which was case law, it wasn't statutory law, meaning it came out of case. And the way it read was, the person who knows the patient best and has their best interests at heart, which meant that it was that sort of vague. But what it meant was, and what the Pacific Center for Health Policy and Ethics used to teach people, is if it's the gay partner, who's been there for 20 years and is saying the patient wouldn't want, at that time there was an AIDS crisis, wouldn't want X, and the family comes in from Oklahoma and hasn't seen the patient in 30 years, the partner would win because they know them best and know what their wishes would be. But the physicians in California petitioned, insisted that the legislature write the rank order thing into law. And why? Because they always were having these family meetings where people are yelling at each other. And somehow they thought that if you had a rank order for family members, that would stop But I think anybody who works here at the University of Virginia can definitely say that it wasn't like a magic bullet to like stop all dissension at family meetings. So I mean, so I will say that it, you know, I think it was felt in certain ways from the medical profession that it would simplify who they had to speak to. But in truth, even though it says you can, people are not like, you know, like having a show of hands and 3 sisters say yes and 2 say no, so we're going to pull the plug or whatever. I don't think people feel good about that. So I do think it's made people feel uncomfortable, and I can tell you that, you know, especially with this, some of the new things about capacity certification, at least in this hospital, there's been a lot more focus on doing this by the book than in ways that seem to me to not necessarily be.
Right. But that, I've heard that since I've been here, some of this doing it by the book concern, and I think sometimes the medical profession pushes that too far. They want that certainty, and so even if they're not happy with some of those answers, sometimes they prefer the certainty to a better answer. And so, for example, I've heard people say, well, they're the surrogate. We don't think they're really representing the patient's wishes, but we have to follow what the surrogate says, right? And the answer to that is no. I mean, if you think the surrogate is not acting appropriately, then you don't have to, you shouldn't follow what the surrogate does. You know, but it seems to provide a clear answer to have that list, and it provides a comfort in one way, I guess.
It's a comfort of feeling like you're not going to get sued. Let's be honest, that's where it's at.
But I think in these situations, from my understanding, is if there's a dispute going on, you can pretty much tell that there's a dispute going on, and you can tread carefully there, right? And if there's a dispute and you don't think, in other words, it's not going to be, you know, a year later someone comes up and starts saying, oh, you listened to the wrong person. You know, so figure out who's involved now and what their problem is with it. And sometimes you have to go to the court and say, the law doesn't answer this question, what should we do? And they'll decide. We don't need to be afraid of asking the courts to help out in situations if the law is not providing a clear enough answer.
There's also an intermediate step, and that's known as the Ethics Consultation Service and the Ethics Committee here in the hospital that can sometimes help with family meetings.
Right, but they can't make the decision. But to the extent the problem is a communication problem, which is how most of these get resolved, with better communication and some time maybe.
I'm afraid that we've reached the end of our time here. I think our speakers are available for a few minutes following if you still have questions. I encourage you, please come tomorrow afternoon at 5 o'clock back to this auditorium for the discussion with Amy Abernathy and Don Taylor about the current healthcare reform process and the prospects for what changes we might see about end-of-life care. Again, and then join us next week. We have a program on the 4th of November on interprofessional education. That is the Vice lecture for the School of Nursing. The conversation goes on, so please come join it. Thank you very much for being here today. Thank our speakers.